So let us study about brachial plexus. Brachial plexus, here in the diagram you can see this is the network of nerves that is supplying the upper limb, which is formed by some roots, that is C5 to T1 spinal roots, and you can see different components of this brachial plexus, and also finally the terminal branches. So we'll study each one in detail. Brachial plexus is the network of nerves that supplies upper limb. It is formed by ventral rami of C5 to T1 roots. The location is neck and axilla. Prefixed brachial plexus, that means the C4 also takes part in this formation of brachial plexus, and it is major part. Postfixed brachial plexus means C4 is absent but T1 is present, and it also contributes to brachial plexus. That is called postfixed brachial plexus. So components are mainly four, that is roots, trunks, divisions and cords. And finally, you can see the terminal branches of brachial plexus. So if you remember 5, 3, 6, 3 and 5, that is, we have 5 roots, that is C5 to T1, there are 5 roots. And then we have trunks. The trunks are 3 trunks, upper trunk, middle trunk and lower trunk. Then you can see the trunks, each trunk is divided into anterior and posterior divisions. Anterior and posterior divisions. So we have totally 6 divisions. And we have 3 cords. Medial cord, lateral cord, medial cord, lateral cord and also the posterior cord. And finally, the main branches will be 5. Here are 3 and here are 2. There are other branches also we'll study. So there are 5 roots, 3 trunks, 6 divisions, 3 cords and 5 main branches. The roots are present deep to the muscle scalenus anterior, which we'll study later. Coming to the trunks. Trunks, we have 3 trunks, upper, middle and lower trunk. The upper trunk is formed by union of C5 and C6 roots. Middle trunk is continuation of C7 root. Lower trunk is formed by union of C8 and T1. So these trunks are sandwiched between 2 muscles, scalenus medius and scalenus anterior. Coming to the divisions, as we already studied, each trunk is dividing into anterior and posterior divisions. So these divisions lie behind the clavicle. Coming to the cords, we have lateral cord, posterior cord, and this is medial cord. Now coming to the finally, we have the branches. So if you see from the roots, there are some extra branches you can see. So here directly from the root of C5, you can see dorsal scapular nerve, that is one branch coming out. And from C5, C6 and C7, there is one more branch called long thoracic nerve. These 2 branches are coming directly from the roots. From the trunks, only from the upper trunk, you can see 2 nerves coming out. This is nerve to subclavius and suprascapular nerve. From the divisions, you cannot see any branches, but from the cords directly, from the lateral cord, we have lateral pectoral nerve. From the posterior cord, we have upper subscapular, lower subscapular and thoracodorsal nerve. From the medial cord, we have medial pectoral nerve, medial cutaneous nerve of arm, medial cutaneous nerve of forearm. So these are the branches from roots, trunk and cords. Finally, we have the other nerves. So musculocutaneous nerve from the lateral cord along with lateral root of median nerve. And from the posterior cord, you can see axillary nerve and radial nerve. And from the medial cord, we have medial root of median nerve. Next is ulnar nerve. And remaining we have already seen. So, if you observe, median nerve is formed by two roots. One root we are getting from the lateral cord, that is lateral root of median nerve. And the other one from the medial cord, medial root of median nerve. So these two are forming the median nerve. So these are about the branches. So lateral cord is formed by union of anterior divisions of upper and middle trunks. Upper and middle trunks. This is the lateral cord. The branches will be lateral pectoral nerve, lateral root of median nerve and musculocutaneous nerve. All of them have a root value of C5 and C5 to C7. Coming to the medial cord. Medial cord is the continuation of anterior division of lower trunk. So this is the lower trunk. Anterior division is continuation of medial cord. We have 5 branches: medial pectoral nerve, medial cutaneous nerve of arm T1, medial pectoral nerve is C8 and T1, medial cutaneous nerve of forearm is C8 and T1, then medial root of median nerve C8 and T1, finally ulnar nerve is C7, C8 and T1. Coming to the posterior cord is formed by union of all the 3 posterior divisions of all the 3 trunks. The branches totally, there are 5 branches. So finally we have axillary nerve here, that is C5 and C6, radial nerve C5 to T1. Directly from the cord we have upper subscapular nerve C5 and C6, lower subscapular nerve C5 and C6, and thoracodorsal nerve C6 to C8. Thoracodorsal nerve also called nerve to latissimus dorsum. So 5 branches from the posterior cord totally. So directly from the roots we have seen, from the C5 root we have dorsal scapular nerve or nerve to rhomboids, that is C5, and also long thoracic nerve or nerve to serratus anterior, that is coming from C5, 6 and 7. And the branches directly from the trunk, that is only upper trunk, it is suprascapular nerve C5 and C6, and also nerve to subclavius C5 and C6. From the cords we have already seen. So these are the complete branches. So what is Erb's point? Erb's point is a location where the 6 nerves join together. The C5 root and C6 root combine, or they join to form the upper trunk. Each trunk, as we know, is divided into anterior division and posterior division. We also know that the upper trunk is giving 2 branches, suprascapular and nerve to subclavius. So totally it is the junction of all these 6 nerves. It is called Erb's point. So any injury to this area, it will affect it will involve all these nerves and the consequent clinical features. Clinical correlation, mainly brachial plexus injury will cause two clinical syndromes, that is Erb's paralysis and Klumpke's paralysis. So what is Erb's paralysis? Erb's paralysis occurs due to the fall on the shoulder. For example, a fall from a bike or from the back of a horse. The person when falls, there is increase in angle between the head and the trunk, and the upper part of brachial plexus injury will be taking place, especially C5 and C6. Or during delivery, there will be the traction of the shoulder that causes Erb's paralysis. In this, the deformity is called policeman's tip hand or porter's tip hand and waiter's tip hand. So during the receiving of the tip, usually the hand will be in this position, so it is named like that. You can see the arm hangs on the side of the trunk and it is medially rotated in pronation and also adduction of the arm. And what are the clinical features? Adduction of the arm is because of paralysis of deltoid muscle. As we all know, deltoid muscle helps in abduction of the arm. So because of its paralysis, there is adduction of the arm. Medial rotation of the arm because of paralysis of supraspinatus, infraspinatus and teres minor muscles. These muscles actually help in lateral rotation of the arm. So when they are paralyzed, the arm will be in medial rotation. Biceps brachii paralysis also happens. So because of this, the elbow is in extension and forearm is in pronation. And because of involvement of C6 spinal nerve, we have minimal loss of sensation along the outer aspect of the arm. So all these clinical features we can see in the Erb's paralysis. Coming to the Klumpke's paralysis. This is the injury of brachial plexus in its lower part, C8 and T1. So when a person falls on the outstretched arm, the angle between the arm and the trunk is increased and there is traction in the lower part of the brachial plexus. So even during the delivery, when the arm is pulled during the delivery, so there is this Klumpke's paralysis. So the deformity seen in Klumpke's paralysis is called claw hand. It occurs because of paralysis of flexors of the wrist and fingers, C6 to C8, and all the intrinsic muscles of the hand, C8 and T1. There will be loss of sensation along the medial border of forearm and hand, that is involvement of T1. We can see autonomic symptoms also. So there will be Horner syndrome if it is there. Horner syndrome is due to the involvement of sympathetic fibers that pass through T1. These fibers supply head and neck. So when it is involved, we have the Horner syndrome. The clinical features of Horner syndrome are partial ptosis, meiosis, anhidrosis, and enophthalmos. So these are the clinical features seen in the Klumpke's paralysis. So we have seen the roots, the formation of brachial plexus from C5 to T1. Then we have seen the trunks, 3 trunks, upper, middle and lower trunk. Then we have seen each trunk divides into divisions, which is anterior and posterior. Totally we have 6 divisions, and we have again 3 cords, that is lateral cord, medial cord and posterior cord, and we have seen all the branches coming either directly from the roots or trunk or final terminal branches. The key muscles supplied will be the upper limb muscles, which will be dealt later. We have 2 clinical syndromes which we have studied today, that is Erb's paralysis and Klumpke's paralysis. We have seen the cause and the deformity seen in each syndrome and also the clinical features. Thank you for your attention.